Welcome to Episode 9 of IMPACT Medicom's podcast series on precision medicine and oncology, the second episode in a three-part series on ovarian cancer. This episode, hosted by IMPACT Medicom's Sarah Doucette, features a debate on whether first-line maintenance therapy with PARP inhibitors can be considered a curative strategy in patients with advanced BRCA-mutated epithelial ovarian cancer. Participating in this debate are Dr. Taymaa May, surgical scientist at the University Health Network and professor at the University of Toronto, and Dr. James Bentley, professor and head of the Department of Obstetrics and Gynecology at Dalhousie University. Hope you enjoy it.
Hello, listeners. I'm excited to kick off this episode of the Precision Medicine podcast series, which will have a different format than usual, as today we are going to have a debate. So the topic of the debate is also a little different from our past episodes, which have largely focused on the importance of biomarkers to inform treatment decisions in cancer. So in this debate, we are focusing in on a specific targeted therapy, that is PARP inhibitors, in an ovarian cancer population selected by the presence of BRCA-1/2 mutations. So rather than just discussing what markers are important for decision-making, we are really looking at how precision medicine in practice is impacting patient outcomes. So the question we'll be debating today is, can first-line maintenance therapy with PARP inhibitors be considered a curative strategy in patients with advanced BRCA-mutated epithelial ovarian cancer? So I'm happy to welcome gynecologic oncologist Dr. Taymaa May, who will be arguing in favor of the curative intent designation, and Dr. Jim Bentley, who will be presenting the opposing side. So we're going to do this first by giving each of you the chance to introduce yourselves and present your sides of the argument, and then we'll have a chance for some closing remarks. So Dr. May, if you can start it off.
Thank you very much, Sarah, for the introduction and for the invitation. My name is Taymaa May. I'm a gynecologic oncologist at Princess Margaret Cancer Center in Toronto, and I'm an associate professor at the University of Toronto. The focus of my clinical and scientific research is in the field of ovarian cancer, so I am very excited to be able to share some of this data with you. Ovarian cancer has gone through a lot of research and some changes over the last decade, and there's a lot of new information that have come to light with several trials. One of the sentinel trials that we have had over the last few years is SOLO-1 study, which was a randomized phase 3 clinical trial of patients with advanced ovarian cancer who were randomized in a 2-to-1 ratio to receive a PARP inhibitor after primary treatment for ovarian cancer. The patient population in SOLO-1 were individuals with stage 3 or 4 ovarian cancer. They could have had primary cytoreductive surgery followed by adjuvant chemotherapy, or they could have had neoadjuvant chemotherapy with interval cytoreductive surgery. People also with stage 4 ovarian cancer were eligible. All patients had to have a BRCA mutation, either a germline mutation or a somatic mutation. Patients were randomized following completion of all surgical and systemic chemotherapy to receive either placebo or olaparib, which is a PARP inhibitor, at 300 milligrams twice daily in a ratio of 2-to-1. Since then, the initial publication came to light, which showed significant benefit to survival in patients with BRCA mutation who were treated with maintenance olaparib. And since then, there was an updated analysis that was published in The Lancet looking at the longer-term progression-free survival after 5 years. So as a lot of us are aware, olaparib was treated for 2 years, and the group who were treated with olaparib as compared to the placebo had significantly better progression-free survival. So when we look at all comers, 60% of patients were disease-free at 3 years, and 26% in the control arm. This is a significant gap. And in ovarian cancer, it is a disease that is very challenging to treat, and we have not seen such a gap in a very, very long time, not with impact of surgery and not with impact of chemotherapy. So this is one of the few new treatments that has significantly impacted survival. The updated data, 5-year follow-up data of SOLO-1 was published by Dr. Banerjee and team in The Lancet. And it did look at the 5-year progression-free survival. And patients, even after stopping olaparib at 2 years, the benefit in the olaparib-treated group was still noticeable. So at 5 years, 48% of people were disease-free who were treated with olaparib as compared to 21%. This is a very significant, it's a 27% difference, which is remarkable. And then when you look at the subgroups of patients who we as oncologists would consider high risk versus low risk, the low risk population had even better survival. So patients who were treated with primary surgery, who had complete cytoreduction at the completion of surgery and had stage 3 disease, where 56% of those individuals were disease-free at 5 years. This is very significant. We're talking about the majority of patients with advanced ovarian cancer who have not recurred at 5 years. This is a game changer. So I'm going to pass it on to Dr. Bentley.
Thank you, Taymaa. Thank you for that excellent introduction. I'm Jim Bentley, for those who don't know me. I'm a professor in obstetrics and gynecology and currently the head of department at Dalhousie in Halifax, and have been a gynecologic oncologist for some 22 years. So throughout my career, I have seen essentially stagnation in what we do in ovarian cancer. Carboplatin and Taxol came along when I was a resident. It was cisplatin and Taxol initially, then we switched to carboplatin and Taxol. And we tried several different modalities in maintenance therapy that really haven't pushed the curve of survival much over these years. It is great to see the data that has been presented and Taymaa has introduced to us today. And it's great to see that we do have these wonderful advances in a subset of our patients. And I think what we have to bear in mind is what are the limitations of this trial and what is the smaller set of patients that we're really dealing with here. So this is a set of patients that had a germline mutation in BRCA1 and 2. If you look at the data, there was only 1% of them that had a somatic mutation. So we have to be careful how we sell that to our patients, and we don't know all of the data about what that really means. If they had, as in this population often will have, they will often have had another cancer. And they weren't excluded if they had a breast cancer, but they had to be treated for early disease, not on therapy, and have had it 3 years in advance. So again, I don't see many patients who come through that are just finishing breast cancer therapy and then flipping over to having ovarian cancer therapy, but that does happen, and they were excluded. So we had that tenet thrown in there. This is a therapeutic option, and we are then trying to improve the overall outcome. In this trial, we're talking usually about progression-free survival. And when we're looking at the actual overall survival, we have to tease that out and see where we are. And I would say, yeah, it is great. I mean, if you actually look at the overall survival at 5 years, you may actually be up to 70% plus of people who have overall survival. Of about 25% of them are still on some form of some sort of treatment or having some recurrences at that time, but they have been through the olaparib setting. What we don't know for these patients is whether they're getting a PARP inhibitor twice, what are all of those things. So it's very difficult to argue against this data that says that survival is increased overall, or to say that progression-free survival is increased overall. But I just wonder about what we are promising our patients and subjecting them to by saying to them, when I initially see a patient who has a BRCA mutation, I can cure you of this cancer. And are we making false promises? Because we need to avoid, one of the first things we do as a physician, we first do no harm. And when we give patients therapy, it does come with harm. We know that olaparib has the risk of nausea that is significant. It has the risk of myelosuppression, and it has the risk of about 1% or 1 to 2% of an acute myeloid leukemia. So there's all of those risks that are involved. And so it isn't a simple panacea. And I believe in the trials, only 50% of the patients who were on the olaparib arm finished all of their therapy. So I think we have 5 years of data. That is amazing. Is 5 years long enough to tell somebody that they're cured? If you are 40 when you are diagnosed with your ovarian cancer, 5 years doesn't mean as much as if you're 70, 65, 70 when you're ovarian cancer. These are people that have a BRCA mutation. They may actually be younger. And to say I can cure them with 5 years of data is a little bit much. If we are saying that we can cure 50% of our patients, which may be the case in this small subset of patients, what in their minds coming into this is a 50% cure rate mean? Only 50%? You can give me a 50% chance? When we explain to other patients in oncology that they have a 50-50 survival, that's pretty doom and gloom. And I know this is a great advance, but I think we have to temper this with this is the first step forward in the precision medicine for these patients, and just be careful about how we explain that to our patients and don't really cause too much excitement. This is a study. Study patients tend to be younger. They tend to be more motivated. They don't represent the general population. And when we extrapolate data to the general population, they don't do as well. I had a conversation with a BRCA patient this very morning, and she's third-line therapy, failing things and taking her off therapy. And I'd had a very optimistic conversation with her 2 years ago when I found out she had a BRCA mutation. And then that just brought it home to me that we have to be cautious about how we have these conversations with people and have some humility about how we do this, because we are not promising everything.
So I think Jim put the challenges very eloquently. I agree that the wording is important. We often, in ovarian cancer and in many other challenging cancers, we use the word remission rather than cure. And I think it is important to be honest and to have the data available in a very clear way. This is one study, but there are multiple other trials that have looked at different factors. And when you put everything together, you start to understand that there is a subgroup of patient that has a different tumor biology where they actually do really well. And of course, there would be, unfortunately, a group that we still need to work on a little bit more and understand the tumor biology better and figure out better targeted therapies. But there is a group that qualifies for primary cytoreductive surgery, and we have shown in multiple trials that the outcomes, if patients have complete cytoreduction, is better than if they have residual disease or suboptimal cytoreduction. Survival is clearly linked to residual disease. So surgical complexity and comprehension in surgery is critical to survival in those patients. And whether it is the surgical effort or whether it is tumor biology that lends...
Yeah, because we know, there's that data that says that the BRCA patient is more debulkable. I think you've got...
Correct. We just published that actually in the Gynecologic Oncology journal just this month. So we have looked at our patients who have a BRCA mutation, somatic or germline, and a lot of them had a somatic mutation, and patients who didn't. The first author was our fellow Dr. Rachel Kim, and we found that patients who have a BRCA mutation are more likely to have complete cytoreduction and hence better survival. So it's a combination, and I agree, the tumor biology lends itself to primary surgery. But we as surgeons have to identify those patients at diagnosis and offer them primary cytoreductive surgery because we know that gives them better survival. When we select patients that will be appropriate for primary surgery, who hopefully will have a BRCA mutation, who might benefit from olaparib, that subgroup of patient has a possibility of very delayed recurrence or a cure. And I think we have to start to feel confident in ovarian cancer to use that word.
So do you think, just to get to that point about, could we identify people before surgery who have a BRCA mutation? So the only ones we are lucky enough to do that are really those that have a strong family history.
Yes.
We have no way of doing a rapid BRCA test that comes back in 2 days. Yeah.
Not in 2 days, but we can get somatic BRCA testing if you have a lab at your institution within 2 weeks, which often is if you have a biopsy, a diagnosis, and then with imaging, we can get the results within 2 weeks. But
So then you're saying that if it's somatic, and these trials we're discussing really did not, I'm trying to be the devil's advocate here, but these trials did not discuss, there was only 1% of somatic mutations within that. So, if you got a tumor mutation, it may well be that most of those are germline mutations. We just don't know that yet.
True. They may not have a germline mutation, but even our own study, which we just talked about, looked at somatic mutation, and they had equivalent survival to patients who had germline mutation. So whether the driver is germline or somatic, the outcome is the same.
Yeah.
That the response to the olaparib will be similar.
Yeah.
I think another important point, Jim, is when we see patients with ovarian cancer, if they are resectable, we should prioritize primary cytoreductive surgery as opposed to neoadjuvant, because that would put them in the lower risk group if they are BRCA mutation. If they do not have a BRCA mutation, they will still benefit from having complete surgical cytoreduction upfront.
Yeah. Do you, in your group of these patients, you see more of these than I do, I think. Do you do intraperitoneal chemotherapy on these at all? Does that come into the mix in this, and then following that with olaparib?
That is a brilliant question. So obviously in SOLO-1, they didn't do intraperitoneal, they did intravenous chemotherapy. At our institution, we still do the original GOG 172 protocol with cisplatin and Taxol.
Yeah.
And the survival rates we see are very similar to SOLO-1.
Without olaparib?
With olaparib. Correct. And even without olaparib, we've published a paper, a retrospective Canadian cohort study looking at over 850 patients with advanced stage 3 C and 4 ovarian cancer across 4 major cancer centers in Canada, and looked at survival based on surgical outcomes and based on primary surgery versus neoadjuvant. And the survival, again, was highest primary surgery. And this is our Canadian population.
Yeah, so that's the primary surgery, but then what about the IP?
And IP patients had best outcomes.
Yeah. So I don't know how we put that in the mix. That's, that's part of that complication about where we go with that. In the trials, they used myriad testing.
Yes.
For germline mutations. We don't know what they are really doing with that because it's a proprietary test and it's not open source or anything like that. Do we have full confidence that our in-house testing that we do in most of our Canadian centers is compatible with that and not missing things? And
that's a good question. I think HRD testing is an important component. And to date, we don't have access to HRD testing. At least we don't in Toronto, unless it's self-paid by the patient.
Yeah. But even the HRD is an even bigger group. But for the group of patients we're talking about now, are the germline testing, are they testing exactly the same mutations in the myriad testing to get BRCA positive that we would test? I would hope they are. I would hope the panels are exactly the same. But we want to make sure we don't miss people. As the GOC said, we need to leave no woman left behind. I mean, we need to make sure we include all the women in the testing for this and go forward with that.
I agree. Validation of local lab testing of the BRCA mutations should be validated. And I think our lab at least is validated and it is equivalent in the BRCA testing. Yeah. But to date, we don't have access to non-BRCA HRD testing locally.
So we're arguing around the same side of the question, and we're arguing about terminology. I mean, we have data for 5 years. Are we ever going to get data for longer in these patients? Because I would bet, if these patients that were on olaparib for 2 years, and then these are the patients that have self-selected, and there's in that 70% that have not got or still alive at the 5-year point or whatever it is, there's a huge group of women in that group, in that set. Are they going to get a second PARP inhibitor? Are they, and there's lots of unanswered questions there.
But I think another important group, the high-risk group, so the stage 4 patients, the neoadjuvant patients who had residual disease up front, still had a significant benefit with a hazard ratio of 0.35, which is very significant. Clinically, at 5 years, 40% of people hadn't recurred. So if you imagine your patient with stage 4, 42% to not have a recurrence at 5 years. And so they have had disease-free 5 years, disease-free interval, which is clinically significant. Quality of life, of course, would be very good. And they were on maintenance therapy for 2 years. So those patients would have been off maintenance therapy for 3 years with good quality of life, minimal side effects, and disease-free. I think this is significant. This is really significant.
I'm not doubting that, I think.
Yeah, I agree. I think this is very exciting paper. It's statistically significant and also clinically very significant. And like Jim said, it's changing our discussions with the patients in practice. The word cure can be used. I use it later on. Up front, we are all hesitant because, like Jim said with his patient today, it is hard to predict who those self-select patients are going to be, but they exist and they will be in our practices.
Yeah. My conclusion would be, I think I was going to say, Taymaa, this may be the right thing to say, but we just have to be very careful about how we say the word cure to our patients and prolonged survival. And we are out to 5 years, and it may translate to even longer survival.
Well said, Dr. Bentley. I echo that.
Thank you.
Yes, I think you guys both just came around to kind of a middle point, and we can all agree that, first of all, BRCA testing is very important to identify those patients. They have clearly a different biology, different prognosis, and that the SOLO-1 data was definitely some exceptional data, and it's good news for the patients, whether or not it's defined as curative or not, I think. And it certainly can be curative, but it's important to be kind of cautious or careful how you discuss it with the patient. So I don't know if any of you have anything else to add.
I think, that's a really good summary, Sarah. We agree.
Yeah. So I don't think I want to decide who won this debate or not, but as we post it on social media, we can let people comment on what they think. But thank you both so much for participating. It was a really great discussion, and we'll hope to have you on again soon. So thanks.
Thank you. This is very exciting, and hopefully more data will come out and more promise in ovarian cancer research.
Absolutely.
Exactly.
Thanks.
Thank you.